invented the mercury manometer. Carl Loving invented a kilogram using pan. Nicholas Russian who initially described the systolic and diastolic both blood pressure. In 1808, first antihypertensive was diagnosed. Sodium thiopentane. Initially, they described description of hypertension as a disease. In 1911, they coined essential hypertension. In 1928, malignant hypertension with end organ damage like retinopathy and kidney disease.
Before that, what is their name? What is there in the name?
In hypertension.
You label as a hypertension.
Yes.
Previously it was not known. No patient was there.
Initially, it was first diastolic.
This was the Western view
Okay.
of hypertension.
Okay, sir.
Right? In our pulse, 4 parameters were being seen. Huh? Tension was seen. What it indicates? When he was knowing the hypertension, but it was not labeled.
Label, okay.
Right? Now you label the entity. Tomorrow somebody else will entitle to another name.
Another.
It is a vascular endothelial dysfunction. It is the same thing we are talking as such. These are all the
Label.
label of a Western people view that blind man seeing the elephant.
GNC1 guidelines in 1977. Initially, it was only diastolic blood pressure that was as a hypertension more than
Who coined first? Muhammad coined first.
point.
He documented. Then these people came in the picture.
Muhammad point.
Muhammad.
Okay.
Not
Muhammad point.
people, you will get the idea.
GNC2, it was again diastolic blood pressure, grade 1, grade 2, grade 3. More than 115 is grade 3 and less than 90 is normal. JNC3 and JNC4, they included systolic and diastolic blood pressure, which was more than 85 was high normal, mild, moderate, severe 90 to 104, 105 to 14 and more than 105. Systolic was less than 140 and isolated systolic hypertension is more than 160.
सर हमारी प्रैक्टिस तो 1984 में लानी है सर तो तुम्हें तेरे डायस्टोलिक ब्लड प्रेशर ने ट्रीट करता नहीं जस्ट आई एम आस्किंग यू के क्या गाइडलाइन प्रमाणे तो 1984 मध्ये सिस्टोलिक ब्लड प्रेशर नोट करेल
પણ સર હું માનું છું ત્યાં સુધી સર તમે એ ગાઈડલાઈન ને બધું તે વખતે હતું આટલું એક્સપ્રેસિવલી કોઈ
Mild, moderate and severe. That was the thing as such. Then whether the cardiac organs are involved or not. That is the second. Third thing, what is the probable cause for the etiology? And what is the approach to that individual according to the data given? This was our practice as such. So, how many hypertensive people are using the fundus now?
None, sir.
Right? Why? And you talk of retinopathy. Kit classifications 1, 2, 3, 4. Right?
It should be done, but nobody is advising. That's why.
Nobody has trained from that.
Everybody knows that retinopathy thai, kidney man, nephropathy thai, but investigation.
Nobody is trained from that point of view. See, we were using the fundoscopy and seeing there is an arterial thinning or not, arteriovenous leaking is there or not, exudated hemorrhage is there or not, and papilledema is there or not. This is the kit classification of retinopathy in hypertensive people also.
GNC 5 and GNC 6 classification is same. Less than 130 was normal. Stage 1, stage 2, stage 3 more than 140, 160 to 180, 180 to 210 and more than 210. In GNC 6 it was mostly same. GNC 7 was updated where less than 120 and diastolic less than 180 was normal. 120 to 140 is pre-hypertension or high normal. Stage 1 is 140 to 160 and stage 2 is one more than 160. In JNC 17 guidelines was updated. Same here, same 120 to 130 is pre-hypertension or high normal. 130 to 140 is pre-hypertension, 140 to 160 is grade 1 and 160 more than 160 is grade 2. In latest ACC guideline, which is 120 is normal, 120 to 130 is elevated. If blood pressure is 130, you are high blood free elevated hypertension. Stage 1 is 130 to 140, stage 2 is 140 and higher. Severe hypertension is more than 180, emergency is more than 180.
Who decides this thing?
ECC, American Heart Association,
How?
based
See,
on
you don't go on a number. If 120 to 129, you have fixed the point. And the process is dynamic.
Pharma company representative.
Process is the dynamic, it is not a static process. Right? So, somebody is having a less than 120, no, you are hypertension. And 121 you are hypertension. This is not the science. It is a continuum process, dynamic process. They have fixed it. From what point of view they have fixed it? Epidemiological point of view. Right? That this was blood sprint trial. From epidemiology.
2015. Treatment evaluation. First, sodium thiocyanate. Secondly, diuretics, thiazides mostly.
Just a minute, go by. Sodium thiocyanate, what it does?
It's byproduct of sodium nitroxide.
So what it does?
What it does is, I think, it is used in not primarily as an antihypertensive. It does, I think.
It is an extremely potent vasodilator.
That's what I okay.
Right? People used to use the sodium nitroprusside as a drip in a very
Emergency.
hypertensive emergency. But the problem was what? Cyanide.
Side toxicity. This is the byproduct of sodium nitroxide. Firstly, thiazides, then 1960 beta blockers, then calcium channel blockers, and
Before that,
Before that.
where chlorothiazide came.
Before?
From where this diuretic came? Thiazide. Sulfur.
Sulfur.
It's a byproduct of sulfur. Chemists used manual the sulfur and found that sulfur is having a versatile action. And one of them thiazide diuretics.
Same sulfur we poisoning.
Antibiotics.
Sulfonamide.
See, if you see the antibiotic inception were also simultaneously going on. So sulfanacydic is a more બધા actions હતા. One of the action was diuretic action.
So,
Anti-thyroid, anti-diabetic. You name it as a sulfur has changed the whole scenario of pharmacology.
Base of antibiotic development.
It was not antibiotic.
Sulfur.
It was chemotherapy.
1950.
Because it was not a biological substance.
Yes, true, exactly.
There is that Rizarpine, the Patel pin, because massively used in India. There is Where do you put this?
The reason is it was introduced by Rustam Jarbati
Recipe.
in 1950. He found that Sarpagandha is responsible for reducing the blood pressure. And he identified from Rawalpindi Sarpagandha to Reserve.
એટલે સેન્ટ્રલી એક્ટિંગ તમારી જે આવે ને એની અંદર
Central
આટલું હોવું જોઈએ.
acting.
આપણું ઇન્ડિયન
તમારા 1960 પહેલા 1950 ને 60 ની વચ્ચે ઇન્ડિયન પ્રોડક્ટ આવશે.
ઇન્ડિયન પ્રોડક્ટ આવો જોઈએ.
એટલે તમે ઇન્ડિયન પ્રોડક્ટનો મેન્શન કરો.
Rustam Jarbati.
જે સરે કહ્યું ને એક્ઝેક્ટલી સર સેન્ટ્રલી એક્ટિંગ.
હિસ્ટ્રી તમારી વધતી જાય છે.
તમારી 50 સ્લાઇડ આજે પૂરી નથી થવાની.
And that product was killed by Western people. Surpassing. We have used plenty. Cheapest drug. Adolphine acid
એમાંથી એ લોકોએ અર્કામિન કાઢ્યું, પ્રોટીનિન કાઢ્યું.
Sir, as sir said.
So previous speakers, are you in hurry? What did James Black did? He found out beta blocker. How? I am the man of history.
We know, sir.
Right? First drug was DCI from Imperial Chemicals. And they found that it creates the beta blockers. James Black was awarded Nobel Prize for what? Not only beta blocker, but S2 blocker also. In acidity, we are using the ranitidine. Huh? That is a byproduct of James Black.
જો આજે સાહેબ આવ્યા ન હોત ને તો તમારો ટોપિક ની અંદર જે હિસ્ટ્રી ને ફ્યુચર લખ્યું જ નહીં, હિસ્ટ્રી અધૂરી રહી.
હવે કઈ વાંધો નહીં. અમે ઓલ ટાઈમ રહ્યા.
બધા બહુ મજા આવે.
એટલે જ યાદ આવ્યું કે તો અમને આટલું નહોતું ખબર.
Current approach, as we know, patient comes in clinic, we measure the blood pressure. If he's young, in every stage of hypertension, we promote mostly lifestyle modification, and we reassess the patients after 3 months or 6 months and 1 year. If in grade 1, we again promote lifestyle modification, we reassess after 3 to 6 months. If blood pressure is normal, then we can continue lifestyle modification. If the blood pressure high, we add the antihypertensive and we reassess after 1 month or 3 months.
24 hours
And
on એ વખતે મને એના હાઇપરટેન્શન જ આવશે. This is my clinical experience that topic. અને કેટલાય લોકોની એન્ટી હાઇપરટેન્સિવ મને બંધ કરવી પડે.
First we add anxiety.
એટલે if I find a clinical scenario anxiety disorder નો વધારે છે then that is causing hypertension. For 15 days I give them anxiolytic. I measure the blood pressure after 15 days and if I find that the blood pressure under 1070 થઈ ગયું છે so I do not address hypertension. This is my experience. તમારું
What is that? My first question was
yes.
that. Once you label it, we write known patient of tuberculosis. Without confirming that on what grounds the tuberculosis was diagnosed. From imaging somebody diagnosed tuberculosis, it may not be tuberculosis. Unless you demonstrate a live viable mycobacterial tuberculosis, you cannot say it is tuberculosis. Right? So similarly, blind men seeing the elephant. Hypertension, all are same, all people are same, start antibiotic. Hypertension is a heterogeneous disease. We put it as a homogeneous. We have not dissected till the mechanism of, in a given person, genesis of hypertension. And there comes nature and nurture. Genetic background and environmental factor. See, these two things are very vital. We hardly address the nature. In the history, how many people take the 3-generation history? See, that's the thing as such. And nurture, social background, working background, his expectation. See, man, his diet as such. How many mamas and padmis are getting hypertension? And how many people from Alkapuri get the hypertension? Right? So it is a spectrum.
I'm just asking, हमारा actually माने तो ना और I know patient young boy मैंने लाइक कि mostly there is no etiological factor के that
No,
can
no
cause
etiological.
non-etiological.
See, because putting idiopathic is a very simple thing. Without doing any exercise, you put as an idiopathic. Then after some time you realize that we had a Crohn's disease as such.
So there is a very important point in Harrison mentioned that if you find a patient, especially જે આ patient જેમાં તમે કદાચ antihypertensive બંધ કરવાનું વિચારો છો, right? હવે there are some secondary causes which are episodic hypertension.
Absolutely.
Right, so in this type of patient, when you find whether it was anxiety or not, that is a secondary thing. But if you find that there were records of 180, 190 blood pressure, and in your case the blood pressure is 110/70, always rule out end of the damage. Do fundoscopy, do echo, do ECG, do UACR, and if everything is normal, then chances of anxiety will be high.
And
But
HCR.
you will find a patient of normal blood pressure having retinal issues, right? So that it is most likely pheochromocytoma, right? Episodic hypertension. So this is a very important point.
In that case, ABPM is also very equally effective. ABPM ની અંદર they had asked how much time of the day it is elevated. So episodic છે કે નહીં એ પણ તમને anxiolytic છે કે નહીં તમને accurate છે કે નહીં એ ખબર પડે. So there are definitely a parameters in ABPM that you can not on a single reading.
Pheochromocytoma is there. It's a disease of triad. We don't see the triad. Headache, palpitation.
Episodic palpitation.
Right? This triad, if one is lacking, chances of yours are much less.
A clinical
How many cases have you seen of pheochromocytoma in your career?
I
4 to 5 patients I have treated.
have seen around 16
I have
cases.
seen the
16, 16.
4 or 5 in 30 years. My
But primary aldosteronism around 8 to 10 and pheo નામે 16 કે 17 કેસ છે જે મેં ડાયગ્નોસ કર્યા.
At the age of
Primary aldosteronism છે ને, we do not investigate in a right manner. But if you ask me, the resistant hypertension I have seen, moment you add after 3 drug, તમે 40 drug cardiac add કરો અને એનું blood pressure remarkably reduce થઈ જાય. So you consider and
this is not conceivable. I am putting. Commonest cause of secondary hyperaldosteronism is the central obesity. Right? So if somebody is having a central obesity and hypertension is there, add the mineralocortical receptor blockers. That is working more than the other drugs.
So if you go by data, the prevalence of or rather incidence of primary aldosteronism across all the regions in a patient where you are suspecting secondary hypertension, it is 5 to 15%, which is not less. Similarly, the incidence of pheochromocytoma in last decade is recorded up to 6 to 8%. Unfortunately, in pheos, normotensive PPGL, that is pheochromocytoma and paragangliomas, are also there in the tune of 30%, right? Because nowadays the imaging is increased, the incidentaloma, so these patients are getting evaluated, but they are still normotensive. It is very apt that in upcoming years he will become hypertensive, right? So it's very early detection. In endofield, it is very, very common nowadays. Okay, so secondary hypertension now it is very, very important. Dalal sir if your patient is truly resistant hypertensive, you add an aldactone, it is highly unlikely that blood pressure niche na aave. Almost niche aave. Almost.
Absolutely. That is the treatment for Crohn's disease when you cannot operate. Use the lifelong aldactone or application.
there are more than see that you don't remove it.
No, and you have to see the potassium.
What is
Every time you have to see the potassium.
That is clinical diagnosis of primary immunity. After વિશ્વામીએ કહ્યું એ પ્રમાણે એમણે કહ્યું that is clinical diagnosis of primary and the incidence are nearly 5 to 6%.
5 to 15%.
5 to 15%.
And another important update which came last year is that if you want to rule out screening માટે તમારે કોઈ પણ મેડિસિન ચાલતી હોય તો તમે સ્ક્રીનિંગ કરી શકો છો પ્રાઇમરી આલ્ડોસ્ટેરોનિઝમ નું રાઈટ ધેટ ઇઝ આલ્ડોસ્ટેરોન લેવલ રેનિન એક્ટિવિટી અને આલ્ડોસ્ટેરોન ટુ રેનિન રેશિયો ઇનિશિયલી શું હતું પેલાની ગાઈડલાઈન એવું કીધી હતી તમે 3-4 અઠવાડિયા બધી દવા બંધ કરો ખાસ કરીને રેનિન ઇફેક્ટ થતું હોય એમાં એટલા માટે પણ સ્ક્રીનિંગ માટે યુ ડુ ઇટ એટ અ સ્ટ્રેચ પછી જો એમાં પોઝિટિવ આવે then પ્રિપેર કરીને ફરી રિચેક કરવાનું then you evaluate right
It is because normally aldosterone antagonism aldosterone renin inhibitor escape થતું હોય છે.
exactly
That is reproduction of renin.
it's not only aldosterone there is ACE inhibitor beta blocker affects the most highly this thing right so screening કરવું is now easy screening માં positive આવે that does not always mean that it is primary aldosterone then you need preparation and then you go for another test
એમાં એક બીજો લેવલ લખ્યું છે કે aldosterone level more than 15 આવે in spite of કે taking drug most likely to take Cohen syndrome level
એકલા aldosterone level પર ના થઈ શકે
that this is what I want to say.
Aldosterone renin ratio.
રેનિન એક્ટિવિટી ને રેનિન રેશિયો જોઈએ
Renin ratio.
So newer drugs are
But
they are
before
working.
that, go clinically. And two things are missing very clinically. Is seeing the blood pressure in both sides. And examining the dorsalis pedis. Femoral. I have diagnosed 2 cases of coarctation only on this test.
that coarctation માં chest pretty noisy હોય છે.
તો પછી આસ્કલ્ટેટ કરો ને પહેલા તો તમે ઇન્સ્પેક્શન ને માર્કેશન
another clinical point since clinical is there what is silent gap or auscultatory gap for ખાસ કરી residents માટે સાંભળ્યું છે ક્યારે what is auscultatory gap આ જેને વકીલ બોલવાલા વાંચી ખબર હશે
હવે એ લોકોને જવાબ આપણને
આથી પણ તમારામાં વકીલ બોલવાલા હતી ખરી તમે નામ સાંભળ્યું છે કે નથી
મેડિસિન વખતે ક્લિનિકલ માં વકીલ બોલવાલા વાંચતા
So first always palpatory method થી BP કરવાનું for systolic pressure. Otherwise auscultatory gap miss થઈ જશે તો the systolic pressure will be low.
what is auscultatory gap એટલે એ એક્ઝેક્ટ છે શું you don't know there is many elderly hypertensive patient જેમાં ભાઈએ કીધું કે પેલા પાલ્પેટરી થી તમે જોયું સપોઝ 160 આવ્યું તો 160 to 20 to 40 વધારે તમારે જ્યારે ઓસ્કલ્ટેટરી મેથડ કરતા એટલું કફ ઇન્ફ્લેટ કરવાનો કારણ કે ઘણી બધી વાર એવું થાય કે પેલો કોરોટ કફ સાઉન્ડ આવે માનો કે 180 આવ્યો પછી there is a gap there are no sounds at all 130 140 એ ફરી સાઉન્ડ આવે જો તમે ઉપર લેવલ ઇન્ફ્લેટ ના કર્યો તો તમે 130 ને સિસ્ટોલિક બ્લડ પ્રેશર કહેશો so you will miss the blood pressure this particular phenomenon is called auscultatory gap
Reason behind it, sir?
mostly hard arteries because of elderly atherosclerosis plaques are more in this type of arteries કારણ કે પેલું એકદમ સ્ટીફ હોય ને તો ઇનિશિયલી આવી જાય
That is known as pseudo hypertension. If you measure the blood pressure in a 70 plus, you get a systolic more and diastolic less. Because you are not measuring the intra-arterial blood pressure. You are not putting a cannula to measure the blood pressure. You expect that the arterial wall are still compliant on compression as such. They have become stiff. So you have to use more pressure to obliterate that pressure. It is the physics come here. So people used to treat that hypertension 170 by 90,
Just like AR na JV.
right? And make the patients miserable. They are having syncopal attack as such, they get the infarct. Because that was not the real blood pressure. Their intra-arterial blood pressure was 130 by 70 only. So in the elderly, this sprint trial is a focus, take it from me. Right? They have not seen from this point of view.
કપૂર તમે મિકેનિઝમ શું કહ્યું
હાર્ડ આર્ટરી
Because of hard artery.
હાર્ડ આર્ટરી એટલે દબાઈ
એથરોસ્ક્લેરોટિક
પછી છૂટે ને તો
that is in elderly only
મોસ્ટલી
Mostly.
એટલે પછી
To
પ્રી atherosclerosis હોય તો ડિફરન્સ હોય
પત્યું હવે.
આજે પ્રેઝન્ટમાં મજા આવે છે.
I think we will not
આ
be able to.
3 બુધવાર ચાલવાનું છે.
મજા આવે સર હું કારણ કે હાઇપરટેન્શન ઇઝ રૂટીનલી મોસ્ટલી બધા પેશન્ટને હાઇપરટેન્શન બધાને અલગ અલગ કોમોર્બિડિટીઝ સાથે અલગ અલગ પ્રોબ્લેમ્સ સાથે
So hypertension is not a disease, it is a syndrome. Just like diabetes, there are multiple pathophysiology. Deep cancer જેમ આવી રીતે બી આવી જશે. It is not a disease.
It is a disorder. Even not syndrome, it is a disorder. Disorder of the existing kinetic system as such.
હું પેશન્ટ રીડિંગ લઈને આવે ને કે સાહેબ મારો બ્લડ પ્રેશર વધી ગયું તો એ તો મોનિટરને રોગ છે તમને શું થયું મોનિટરને રોગ થયો ને 160 90 આવ્યો તો મોનિટરને આવ્યો તને શું થયું એ બોલ ને
એટલે મને સર એવું કે પેશન્ટને અગર અડધા પેશન્ટ એવું કે મને તો કશું થતું નથી આપણે તો એવું we treat the blood pressure not the symptoms because they are silent killers.
more than 90% of patients do not have symptoms.
હા
It is a screening disorder.
હા પણ અડધી વખતે અડધા મતલબ મેં જોયું છે કે 150 160 હોય તો પણ ટ્રીટ કરતા નથી reason
There is always an acceptance issue. If your patient are not complaining and blood pressure આવે છે તો તમે દવા લાગશો તો બી most likely he is not going to take. Right? એટલે કાઉન્સેલિંગ કમ્સ ફર્સ્ટ. એટલે થરો ઇવેલ્યુએટ કરો. તમને આ 160 બ્લડ પ્રેશર પર એમનું ટીએમટી કર્યું હોય અને એ વચ્ચે હાંફી જતો હોય then he will realize કે બની શકે એના ડે ટુ ડે લાઈફ માં એક્ટિવિટી ના કરતો હોય is absolutely asymptomatic. Right? So that is why thorough evaluation is important.
એટલે it's a silent killer. તમારે એમ 500 ડાયાબિટીસ વાળો બી કરતો હોય છે અને 100 વાળો બી કરતો હોય.
એટલે normally
Because you are
experience
seeing the heterogeneous group. Once again I put it. I will give a story. I have told several times this story. William Gordon, who was in a Brigham hospital. He was the chief of hypertension. He told that one patient came to me for hypertension, and I saw he was a truck driver from New York to San Francisco. He prescribed some drug as such. Then next visit did not respond. Third visit did not respond. He was altering the drugs as such, understanding the mechanism. Then that driver asked a simple question. Doctor, do you know my problem? Or you are doing the trial and error to me as such? We are doing trial and error to this as such. Using this drug, not working this drug, not this combination, without realizing what creates the problem in that given person as such.
but this is how we treat the hypertension.
This is how we wrongly treat the
Wrongly
hypertension.
treat,
See, the point is this, so the your future is a precision and personalized medicine. He coined the term that those who are AC responsive and not responsive, beta blocker responsive and not responsive. If you see the black Americans, they don't respond to beta blocker.
Amlodipine.
Which means that pharmacogenetics comes there as such. Right? We don't do that thing. We don't understand those things. We go by the genetic background and assume that this drug will work. 70-80% it work. Another 20% you have to go. 8 diabetes, 8 calcium channel blocker. You are doing trial and error. That person knows the doctor. If somebody comes for a urinary infection, what you are doing? You are doing culture and sensitivity, and then give the appropriate antibiotic. Right? In hypertension, why don't you do it as well? In diabetes, why don't you do it? Dyslipidemia, why don't you do it? You treat as a heterogeneous disease as a homogeneous disease.
Strategy for uncomplicated essential hypertension. Firstly, we add a thiazide primary, then ACE-ARB, then calcium channel blocker, and lastly beta blockers. Nowadays, RB is also as a first line of treatment, or
algorithm પહેલા previous slide ની અંદર લીધું ને એમાં Indian hypertension guideline જે ખાસ હમણાં last 2025 ની અંદર they had prepared a hypertension wheel which is very good on just you stick that wheel on your table and you will get everything that has included all phenotypes, that included all morbidities, this dual concept start from the dual combination therapy also everything
and ACBR.
that has been included in that hypertension wheel. Just take a sticker તમે તમારા ટેબલ પર લગાવો and you will get everything. That is very good.
This is ACB and ARB. We all know that we can't give it both together. Watch for hyperkalemia, renal injury, angioedema. That's a general blocker.
Previously. What is the difference between an amycretin and other AC medicine?
Amipril and other.
Lisinopril is there, right? Huh? If you see the patient coming from America, they are on
Lisinopril.
Lisinopril.
40 milligram.
What
40 મિલીગ્રામ સુધીની લિસિનોપ્રિલ ટેબ્લેટ આપણે તો 10 સુધી અઘરી મેળવી હતી.
What amycretin does? Both are AC inhibitors. Amycretin works in a tissue, while lisinopril works in the vessel. So it is the central.
Central acting.
So if you see the whole trial, amycretin is far superior than other AC inhibitors.
All other molecules are perfectly compared with the ramipril basically.
Action channel beta blocker, L type and T type. Diuretics, potassium sparing, diuretics, aldosterone antagonist, beta blockers.
It comes and goes. Atenolol came and goes. Nutrient is nonsense. Pharmaceutical company.
And I have seen most of the patient with atenolol comes with stroke.
How vigorously blood pressure was controlled. That is the more important. See, atenolol was implicated for a central aortic pressure increment. That was a concept put by the people as well. And hence, UDP went away. Now you see less atenolol,
Yes.
less amlodipine also. Now you are coming to the LN blocker.
There are certain people, if you are having a ethanol, patient is on ethanol, and if you try other molecule, they will never get control.
Absolutely.
Same way glymentamine એ જે દેઓનિલ નામની દવા એની ઉપર જો પેશન્ટનો કંટ્રોલ હોય તમે છંછેડવા ગયા તો you will be land up in definitely a problem. Though they are harmful, we know that ethanol and glymentamine, diabetes, but don't try to disturb unless the patient is having some problem. If the patient is very well controlled on atenolol, no guideline says that you should change it.
એને
That is
માટે
very clear.
એક વાક્ય છે ચાલુ ઘોડા અને ચાબુક નહીં
Knee mark.
કાં તો ભટકી જાય કાં તો બેસી જાય.
Topic beta blocker is always an issue.
Really a controversial topic.
હવે કેટલી સ્લાઇડ છે તો પાર્ટ 2 કરીએ 9:30 ને 5 સ્લાઇડ.
તો 10 વર્ષ આપણે ચાલશે ભાઈ.
પણ ફ્યુચર શું આમાં આપણે પેશન્ટ ઉપર આયા
Future, sir.
Invasive treatment because I have nerve block.
અચ્છા એનો ઉપર
Invasive treatment, renal sympathetic denervation, baroreflex activation therapy like barostin.
Who coined this term? Renal sympathetic denervation.
વેક્સિનેશન પર આવી ગયું.
Dr. Bhatt from Brigham. Simplicity trial. Then the went back, again simplicity came again. Simplicity 2.
That is the trial of denervation.
Denervation, renal. Then the son is doing.
activation therapy, mainly concept is decrease the sympathetic and increase the parasympathetic by activation and this is all minimally invasive and reversible procedures.
Reversible के लिए
Not sympathetic innervation, but this baroreceptor activation and baroreceptor activation.
intervention के लिए reversible.
No, not that. These two.
Next week,
Oh,
Next Wednesday करीब नाक जो पड़ता है.
sure.